Good afternoon, all. It is a pleasure again to be with you for another section where today, as yesterday, we had a small discussion about what an implant is and where we are using it, and what are the types of implants, and what are the types of bone we come across. And we had a small brief about which type of implant where we can use. Today, going further, I'll be going into the slight bit of the prosthetic part of it, which will be slightly complicated for you to understand in the beginning. But as the flow goes and I show you the cases, you will be able to grasp whatever I'll be explaining. And then I'll be showing some cases which are done by me and some of my friends where we have placed the implants not only in the simple cases as well as in the complicated cases. I'll just give a overview. But to begin with, as you all are beginners, whenever I start taking the live session as the offline classes to the participants, I usually tell them, whenever a baby is born, he starts crawling first, then he stands, and then he walks, and then he starts running. So when you start your implant practice, don't straight away jump into doing complicated or complex cases, all on 4, full arch. Start with the simplest of the cases. So once you start placing the implants in the simplest of the cases, start with single implant case, then go on to multiple, and then you can go in for full mouth or full arch rehabilitation. If you are well experienced enough and you have placed a lot of implants, then you can go for extra max implants, sinus graft, all advanced techniques, which I'll be briefing as the day progresses. Okay, then as you all are aware, when you started studying dentistry in an undergraduate level, you were not aware about what an instrument is and what are the cements, what are the various surgical instruments we have to use. So once you started seeing them and started using them, you came to know, oh, this instrument is for this purpose. And this cement is for luting. This cement is for filling. The same thing holds good for implant dentistry. As you all are doing crown cutting, the same principle follows for the prosthetic of implant dentistry as well. If you are well experienced in the crown cutting part of it, or prepping the crown and then placing a crown in the best of the occlusion, your life becomes easy. The same thing holds good for full mouth rehabilitation. Your first step in full mouth rehabilitation will be preparation of this complete denture. Get the video, get the occlusion at the right place, and then using that as a template, you will be going for the fixed implant processes. So knowing the basics are very, very, very important. If you are not knowing how to prepare and CD with the best of the occlusion, you will be landing into problems when you start doing the full mouth rehabilitation with the implants. So knowing the basics are very, very, very important. So with this thing, like yesterday, as I told you, we had a discussion about what an implant is, where we can place, what is single tooth implant, what is multiple, what is full arch. So what are the things which come into implant dentistry when we start placing? The part which goes into the jaw or the bone is called the implant. And on top of it, we have something called as an abutment, which holds the crown. This abutment is attached to the implant with an abutment screw. And then on top of that abutment, you'll be placing the crown. So these are the basic components in implant dentistry. So if the patient asks you, what is an implant, what is an abutment, what is a crown? So you will be placing the implant in the jaw, and on the top of that, there will be a suprastructure, which is called as an abutment, which is held to the implant by an abutment screw, and on top of it, you will be placing a crown. So you should be well aware and knowledgeable enough to explain to the patient the process which you are doing. If you're not knowledgeable or if you are not competent, and if you're not able to explain to the patient about whatever queries he has, then it becomes a very difficult job to convince the patient for implants. And luckily enough, Osstem company has wide range of surgical kits and wide range of prosthetic components, which makes your life easy. No doubt, before jumping into Osstem company, I used to use a lot of other implant systems like Magagen, like say Magagen, BioHorizon. I used to use a lot. But once I jumped into Ostium and I started doing the processes, that is the time when I understood, oh, this is how simple the prosthetic is. The component they provide, the multi-units, the angulated abutments, the rigid abutment, the different types of abutment systems which they have, it's amazing. So that made my life easy for the prosthetic part of it. And the second thing and the foremost important part is the support which you get from the company. Absolutely amazing support. I never experienced this type of support with the other companies. Austin people are giving me a very good support. If I want a component, within half an hour to 45 minutes, the component is there in my clinic. That is the type of support which you require when you start implant practice. Without the support of the company, your life becomes hell. I remember a case in the initial stages of my implant dentistry. I had just one implant on my table in the stock, and I started placing the implant. I opened the flap. I think it was 4.2 into 10 implant was decided. We have planned it by taking the RVG, CBCT and everything. And then we opened the flap. We started performing the osteotomy. And when I placed the implant started spinning in the osteotomy. That was the learning curve for me. So just having one implant on the table and starting the case is not at all advisable in implant dentistry. So from that day onwards, I made it sure that I'll be having at least 4 or 5 implants. So if I plan for 4 into 10 implants, I make sure that I have 4.5 into 10 as well and 3.5 into 10 as well. And lengthwise also, I'll have one of 11.5, one of 8.5 as well. That day, I had to, without doing the implant, I had to close the osteotomy and suture it off. It gives a wrong impression to the patient. So make sure when you start practicing your implant dentistry, you have the stock of abutments before you start the case. And as all you are aware, like if you want to do a root canal treatment, there are certain instruments which are required for that. Like you want to have an endomotor, you want the files, you want the broach, you want to have a plugger, you want to have GP point, you have to have a sealant. Something similar is there in implant dentistry as well. What are the basic instruments? There are some basic surgical instruments which are required. And the most important part is the physio dispenser. How should I use it? And the time is very short for me to explain about the physio dispenser and the various surgical instruments. Probably, if you all join the basic course, we'll be brushing through across the various surgical instruments used in implant dentistry, and you'll be trained how to use the physio dispenser, which is the most important armamentarium for implant dentistry. Without physio dispenser, your work doesn't work. You can't place the implants. Let me again tell you one experience of this. I had only one physio dispenser and I had only one handpiece. And I started preparing the osteotomy in one of my relative as well. That was my relative, I think I remember. Yeah, it was my relative. I was supposed to place 2 implants in the region of 3.5 and 3.7. And I was having only one handpiece. And I started doing the osteotomy. First drill was okay. Second drill, I could see all the ball bearings of the bearing coming out in the patient mouth. And the drill was hardly rotating. What shall I do now? So you should be able to manage. Luckily, almost all the end, osteotomy was done. So I started placing the implant with an endomotor. So that is how you should be able to manage. And it is almost all 7 years since I did that, and the patient is doing excellent. You shouldn't panic in front of the patient. Stay relaxed. Don't panic at all. Always there will be a plan B. If the plan A doesn't work, always there is a plan B. So you should be ready with the plan B as well. So proceeding further, I'll go ahead. So this is an implant. On top of it, there is an abutment. On top of it is the crown. So these are the various type of implant systems that are there in Osstem. Very good enough. So the famous one or the most popular one is the TS system. So most of the doctors use this TS system, and some doctors use the KS system, SS system, US system. Very, very rarely we use the MS system, unless and until if we require it for temporization of the denture or a single temporary crown. If you are doing multiple implants and you want to do temporization, we use the single piece implants, or in case of lower anterior or upper anterior region where there is less space, we can use this system. Otherwise, most popular is the TS system. So what is TS system? Transient solution. So it has got its own features, why it is used, and what are the different types. We have the TS2, TS3, and TS4, where exactly each one is used, why there is more taper in TS4 and less taper in TS2. So these are all some of the basic things why each implant is designed in a particular fashion. Like TS2 and TS3 we can use in a heat socket, whereas TS4 we can use in a immediate extraction placement because it is having aggressive threads. So that the biomechanics of each implant design is very, very important. So once you start selecting the implant for the placement in a particular area, you should be aware about the system which you are using. Why there is more taper in this? Why are the threads more sharper? Why are they so aggressive? There is a reason for it. It has not been blindly designed. A lot of research has gone into it. So depending upon where you are placing the site, so as I told you yesterday, the assessment of the site, assessment of the patient, everything has to be taken into consideration before you start deciding about which implant you are going to place in that particular site. So again, the key solution, the KS system we have, and then we have the successful SS solution, and then we have an external connection as well in Osstem system. Some cases we might have to use this. So you're lucky enough that Osstem is providing all the available chances to you so that you can place according to the whatever the case might require. So they have the wide range of implant system which will help you in deciding which system or which type of implant is suitable for that particular case. So you need not have to just keep on placing the TS system. Some cases you might require US, you sometimes require KS. So it depends upon the case. So depending upon the case suitability, you can accordingly decide which system you want to use. This is a micro solution system, as I told you. So it is a single piece implant. So you can't have a error in the angulation. You should be very, very, very precise when you're doing this implant, because if you are placing the implant in a different angulation and in a not in a correct angulation, you'll land into problems when you do the processes part of it. So a definition, what is an abutment? A component connected to the implant with a role to connect the processes through the gingiva. The definition itself says that it's a component connected on the top of the implant with the help of an abutment screw, and it has a role. What is the role? It is to place the crown of the processes. What is the other things? It has the effect. It transfers the master degree forces from the crown to the implant and distributes the master degree forces transferred to the implant. So the abutment plays a very, very, very important role. So what are the main features of this abutment? It acts as a intermediary to hold the crown onto the implant. And second, it transfers the master degree forces from the crown to the implant. And it distributes master degree forces. Of late, I was going to some articles. So previously, we used to place implants of 10, 11.5, 13, 15 of various lengths. And there are a lot of articles which I went through recently. They say that when the master degree forces are applied on an implant crown, the maximum load, the maximum master degree load is just on the 5.5 mm of the crestal part of the implant. So whenever the patient eats the food and applies the masticatory load, the maximum load or the maximum force is on the crestal 5.5 mm of the implant. So whatever is beyond is just for the apical stability or apical anchorage. So if that is the case, we can stick to 8.5, 10 mm implant maximum. But why are they marketing implants of 11.5, 13, 15? There is a reason for that. What is the reason? In cases where we do immediate extraction placement, what will you do if the length of the root is 11? The protocol for the immediate extraction placement says that you should be beyond the apex by at least 3 to 4 mm. If the root length is already 11, how can I place the 8.5 or 10 mm implant? A difficult situation. I will not be following the protocol. I will not be getting the primary stability. So there is a reason why there are different lengths and different diameters. So you should follow the protocols accordingly. So the immediate extraction placements and the delayed extraction, early delayed, these are all the concepts which require half day or 1 day for us to explain to you, and so that you can grasp all the things. So this is just a basic. You should know what is what, so that when you join the program, you will be engulfed in detail about the different types of implant systems, where to use which, and then when to do immediate loading, when to do delayed loading, and what is stage 1, stage 2, everything will be taught in detail in the implant program, in the basic program, which will be for 6 days or 7 days, depending upon which type of program you're taking. Okay. Now going further, the shape of the implant is a 1-piece abutment. It's called as rigid abutment, then 2-piece, and then we have multi-unit. So there are the 3 types of basic abutments. What are those? 1-piece abutment, which is a rigid abutment. What does you mean by that? It doesn't have a separate abutment screw. So the threads are attached to the abutment. So it is a 1-piece abutment. So you will be just screwing the abutment to the implant. Whereas in 2-piece abutment, you are placing the abutment and then tightening it, attaching it to the implant with the help of an abutment screw. Whereas in 3-piece, you have an abutment, then you have a cylinder, and then you have a cylinder screw. So that is multi-unit abutments. Okay, is it clear till now? So going further, we have 1-piece, we have rigid abutment, we have O-ring, and then we have locators. What are these O-rings and locators? I know it is Greek and Latin for you, but once you start practicing in implant dentistry, and once you start using them, you know what is the purpose of it. O-rings and locators are used for O dentures, stabilizing the dentures with 2 or 3 implants or 4 implants. If you are having insufficient bone in the posterior mandibular, you have bone only in the premandibular, in the symphysis region, you can place 2 implants, place a O-ring abutment or a locator abutment, and stabilize the denture. Okay. Then we have two-piece implant. In two-piece also we have various types. The transfer abutment, the popular one. Then we have the temporary abutment, which can be used for temporizing, particularly in the anterior region. Then we have the quick temporary, where we can add either the acrylic or the temporary resin material or the light cure and prepare the crown and give a screw return temporary for the patient immediately. Then we have angled abutments. Sometimes you might not be able to place the implant in the correct of the angulation and the correct of the position, but we have done the procedure. We have placed the implant, and when we see and when you try to place the straight abutment, it is not fitting. So the option of angulated implant helps you in rectifying those errors and correct the case. So there are angulated of 15 degrees, 10 degrees, 25, depending upon various companies. It has 17, 25, 30, 25, 30. So you can use it accordingly. And then we have freeform ST. Then we have Zeosphere, that is the zirconia. And then 1 fit. 1 fit is an excellent option we have nowadays. And then we have the cold cast. So these are some of the two-piece abutments we have. And then we have the three-piece abutments. The convertible. What do you mean by convertible? The name itself suggests. So the internal hex implant gets converted to the external hex by a convertible abutment. So there are a lot of benefits, pros and cons for external and internal. So that itself will take half an hour or 45 minutes to explain what are the pros and cons of external and internal. As I told you, as I keep on repeating, these are the subjects which cannot be explained in detail within a half an hour, 45 minutes, 1 hour, or 2 hours. It should be an interactive section where you'll be shown the component, you can feel the component, and you can remember it. Seeing is believing. Unless and until you see the component and hold it in your hand, whatever picture we show, the best of the pictures we show, it will be just there in your mind for 45 minutes to 1 hour. Beyond that, it goes. I still remember when I was studying implant dentistry in 2008, 2009, we used to write a lot of notes. So whatever the mentors used to give their experiences or the subject-wise, whatever they used to talk and give the knowledge to us, we used to write. But have you ever seen those books again? No. But the same thing, if you do it on a hands-on, if you do it on the patient, and if you have the experience of doing it on the patient, once you see it, you keep believing it. So, seeing is believing. The same principle, I follow it. I never do flapless surgeries. Never do flapless surgeries. I always do the surgeries with flap. I want to visualize the bone. I want to see how the bone is. And I want to see where the implant is going. Is the angulation correct? If you don't open the flap, you are not aware how the implant is going, where exactly it is going. Something similar happens in digital dentistry or the guided surgery. A lab person helps you in guiding. They prepare the guide and they give you the guide. And you place the implant according to the guide. And most of the time, I have seen some cases of guided surgery. They give a guide according to the available bone. Sometimes the angulation error is there. So initially, please do freehand. Don't jump into doing guided surgery in your early implant practice. Once you start gaining the confidence and you are well aware that there is a very good bone, with the length, everything has been falling in place, then you can start doing freehand or flapless. Or you can start doing the digital dentistry, which is taking up very, very fast. delivery of the crown within an hour. So everything is planned. The patient walks in, you ask them to get the CT done, you send it to the lab where they prepare the crown, they prepare the surgical digital guide, everything is in place. You place the implant, you place the abutment, you place the crown and send the patient. And you're earning a lot of money. That is the main. Why are you doing implant dentistry? Why are you listening to this lecture? You want to upgrade yourself. You want to earn more money. And the fastest way of making money in dentistry is by placing implants. That is my experience I'm talking about. As I keep telling you, all cases are not for implants. So the case selection is very, very important. Don't just see the bone and start placing the implants in all sorts of places and land into trouble. So case selection is very, very important. And then we have the multi-unit abutments. And then we have multi-angle. Then we have the cylinders which goes on it. And then the small cylinder screw. So this multi-units most of the time we use in single implant case as well as in all-on-4 cases. So these are the components. These are the different types of abutments we have in Osstem system, which makes your life easy in preparing the processes and helping the patient eat the food, look great, and be happy as well. Okay, going further. So one-piece abutment. So it comes in various gingival height. So depending upon how deep the implant is, you can order the abutments of different gingival heights. So transfer abutment, temporary, then the quick temporary, the same thing again, preform, Zeocera, 1 feet, gold cast, and the NP cast. So most of the time, NP cast, we use it for screw written processes. We send it to the lab. They prepare a abutment and they give it to you custom made. So the 3-piece abutments, same. So then we have connect abutments to the most important part, which holds the abutment and holds it into the implant. And we have seen cases because of the shear forces, or sometimes I have seen people giving a distal cantilever or an anterior cantilever, and the patient comes as a referral to me saying that the abutment screw is getting loosened very often. We have seen cases where there is fracture of abutment screw as well. I have seen cases where there is a fracture of abutment. There is a fracture of implant, flowering of implant. I have seen referrals. I don't say that I'm not having failures. Even I have seen the failures of the implants. Probably when I start taking the basic courses for you or to the others, I might show my failure cases as well. Failure is the stepping stone for success. I don't say that all my cases are successful. Have you ever seen all the crowns staying on the teeth in your prosthetic face, this thing, without coming out? Oh. The patient eats chewing gum, the patient is eclipsed, the crown pops out. Have you ever seen that? In my experience of 31 years in dentistry, you use the best of the cement, luting cement. We have seen cases, the crowns coming out. So you should be very careful when you are selecting and placing the implant. So case selection, diagnosis, treatment planning. And what else? Execution of your plan. So these are some of the things you should be aware when you start doing implant practice. So the basic is selection of the perfect case. So start with the simplest of the cases. Then go for slightly advanced cases, moderate complexes. And then you can go for complex cases. And what are those complex cases? Pneumatic sinus, very thin ridge. What should I do? The patient wants the implant. So accordingly, that will be your stepping stones. So again, these are the cover screws, the healing abutments, blah, 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 the various components where in stage 2, you'll be placing the cover screw and then again opening in the stage 2 surgery. And then you have the stage 1. So these are some of the basics. So again, the healing abutment comes in various gingival height and various diameters. So depending upon which area you're placing, you can use it. So these are the impression copings. Once you see the case, you'll analyze it. Then you have the lab analogs and the burnout cylinders. And this is how the impression is taken with the closed tray, rigid abutment with a cap, the snap over there, and then the open tray and the closed tray. Then we have the lab analogs with the which we transfer the impression coping with the lab analog to the impression and then send it to the lab. They pour it, they push the gingival latch, they send you back the model, you select the abutment. So there's a lot of procedure goes on for the prosthetic part of it. Then we have the burnout cylinders for the cement screw return processes, and these are the surgical drills. So a surgical drill is a most important component. So let me show you one case, the simplest of the cases to start with. So the patient comes to a clinic with missing 3-5. So it looks pretty good enough widthwise. And then the mesodistal buccal looks good. And the IOP also shows a very good length of bone available over there. Then we studied the CBCT. The nerve was very far off. So my life becomes easy. So I did not have to be worried about it. And then we started doing the procedure. So the radiograph with the paralleling pin, radiograph with the implant placed, and the radiograph with the cover screw. So where to place the cover screw and when to place the healing abutment, it is your decision, depending upon the primary stability which you have achieved. If the primary stability is more than 30 newtons or 45 newtons, you can go in for healing abutment. You need not have to open for second stage. If the primary stability is less than 30, pretty good enough, place the healing screw, place the cover screw, close the flap, come back after 2 months for mandible and 4 or 5 months for maxilla, and you'll start doing the prosthetic phase. Okay. And this is during the surgical phase. Opening of the flap, placement of the paralleling pin. See how exactly it in the center, mesodistally and buccolingually. So that is how you should start doing your initial cases. Don't take a case where the ridge is thin, there is hardly any bone, the sinus is very close, the inferior nerve is very close. Don't jump into doing complex cases. Take the help of the mentors. Take the help of the senior doctors who can help you out in managing those cases. But as a beginner, start doing the simplest of the cases. As you start gaining the confidence in doing the simpler cases, then you can start doing slightly complicated cases, grafting, GBR, sinus grafts, sinus lifts. So you can start doing those type of cases. So to begin with, as I told you, start with the simplest of the cases. So then healing abutment placed, close to impression coping, impression transferred, and this is how it was restored. Right. It is not as simple as I told you. You have to follow all the protocols. You have to see what type of impression coping I'm using. Nowadays, the oral scanners have simplified your life. Just place the scan bodies, scan it, send it to the lab within half an hour. They'll send you the design of the crown. You approve it. Within 2 days, the crown is there on the table. You need not to take the impression at all. As the life is becoming easier and easier, the steps are becoming tougher and tougher. Follow all the protocols. I just can't scan. I have to follow all the procedures for scanning as well. Sometimes my scan might not be good. You should be very careful. Am I using a long scan body? Am I using a short scan body? Which one should I use? For full arches, should I use a oral scanner, or should I use a photogrammetry? So it all depends on your decision and how you invest. And for that, we have the basic courses in Osstem implant dentistry. We have the 6-day course where the module 1 will be of 4 days totally on surgical part of it, and then 2 days of prosthetic. So you will be placing the implants in the patient's mouth and you will be restoring on your own. We have seen a lot of doctors show a lot of interest when you are placing the implant, but when it comes for the prosthetic phase, you are very lethargic. Our intention would be to make you a total implantologist, not just a surgical implantologist. If you are able to prepare a crown on your own, then you can plan your surgery very well. If you just want to place an implant, you'll be placing implant in all sort of positions, all sort of angulations. And then when it comes to the prosthetic part of it, you'll be landing into trouble. And you're putting the trouble on the prosthodontist. You say him, hey dog, the implant is integrated very well. I can't remove it. Try to restore it. I have aborted some cases. Refer to me. I have removed some implants and replaced new implants before restoring them. They were in such a bad positions. So planning and then execution is very, very important. So what are those programs? What we do in these programs? We do this program in almost all the major cities in India, where in the basic program, we'll be teaching about the history and basic concepts, and then the surgical protocols. What are the instruments needed? How will you start doing planning your cases? How will you present the case? What are the photographs you will be required? Everything will be teaching in detail. Then, what are the complications you can come across during the surgical phase while doing the surgery? So everything will be taught in detail in those 4 days of surgical modules. And then there will be a demo, and on the last day, you will be placing the implant in the patient's mouth. Live patients. It's a very unique program where you will be placing the implant on your own. And whenever I teach, whenever I mentor in the clinical section, I'll be mentoring or guiding the doctors only in the first case. And from the second case onwards, they are on their own. But I'll be watching it very closely. If something is going wrong, I'll try to interfere. Make sure that patient is not affected. I know you have started placing the implants, but at the expense of the patient. So make sure you give the best to the patient. That is what they have come for. When it comes for the anterior teeth, they have come with the saying that, oh, this doctor is the best, he'll give me the best. And if you're not doing the best, that will give you a negative feedback to your other patients. So the patient, particularly the implant dentistry, it is word of mouth. Oh, I got that implant done in that particular clinic. It was done very well. Why don't you go and get your implant placed in that clinic? And if something goes wrong, oh, that clinic was a mess. I had so much of pain. The implant was very painful. I don't know how the doctor did it. Kindly don't go to the clinic. So how it entirely depends on how you manage the cases. In implant dentistry, as I told you, it is word of mouth. One case you do very good, the same patients and goes and tells for 10 to 15 patients. So be gentle, be careful, do a very good case selection, plan that, do a mock surgery if you want on the model, and then do it on the patient mouth with a lot of confidence. Don't panic or cut a sorry figure in front of the patient. So what do we do in this prosthetic module? The prosthetic module, we'll make sure that you're taught how to take the regular impressions with the rigid abutment, with the impression copings, both open and closed tray. You're taught about the abutment level impression and the implant level impressions. And then we'll be exposing you to the digital impression as well. In some of the cases, we will be teaching you how to temporize and immediately give a temporary crown. And what is the second program we are having? We are having the Master Basic with Digital Implantology, where you will be taught how to prepare the surgical digital guide, how to use the one guide kit. So depends upon which program you take. Accordingly, you will be taught in those programs. So plan in such a way. Suppose if your clinic is having an oral scanner and you have the facility of the CBCT, utilize them. No doubt, the lab persons or the persons who are making the digital guides charge you. Charge the patient. You're not doing it free. You're charging the patient. But your life becomes easy. Explain to them the advantages of digital dentistry. Explain to them how simple your procedure becomes if you start doing the digital dentistry, digital implantology. It comes with price. You know what is QSP of dentistry or implant dentistry? The quality and the service comes with a price. If there is no quality, there is no price. If there is no service, there is no price. If you do quality service, if you do a quality job, and if you're giving a good service, the patient doesn't mind paying extra or whatever you ask for. That is what we are here for. So give quality treatment to the patient, give a good service, the money will flow accordingly. If you are not giving the quality and if you are not going to give service, price will not come. So this is how you should start managing your implant practice. So these are the two basic programs which we have. So if anybody want to enroll, they can enroll. And these are the hands-on which we'll be doing during the course. And these are the persons you can be in touch with in Hyderabad to join the program. And what are the advanced programs we have? So once you finish with the basic programs, you can always enroll for our advanced programs. What are those advanced programs? The advanced programs are sinus management. How should I manage the sinus if it is very close to the ridge, close to the crest? Should I do the crestal approach, or should I do the lateral approach, or should I do zygoma pterygoid? So we'll help you out in coming to a conclusion. Then soft and hard tissue management. I've seen a lot of doctors are very, very lethargic when it comes for the soft tissue. In the implant literally goes into peri-implantitis and fails. So the importance which you are giving for the stability of the implant the same importance has to be given for the pink gingiva as well. So when it comes for implant dentistry, you should take care of both pink aesthetics as well as white aesthetics. So both pink and white plays an important role. Digital dentistry, 2 days course, full mouth rehab, FMR. Most of you are having a lot of CD cases. And most of the cases, the lower denture keeps swapping out. Patient is not able to talk. Patient is not able to eat food comfortably. How will you manage it? Give them the option of fixed processes with implants. So, FMR course, 2 days. Then advanced prosthetic course. So, these are some of the advanced programs which we have in Osstem company. So, join the basic course, get yourself competent enough, start placing the implant, and then jump into advanced course as well. Recently, 4 years back, 3-4 years back, I joined the program of zygomas and pterygoid. Why? The patient comes to a clinic with pneumodized sinus, hardly any bone, thin ridge. The patient wants a fixed option. Patient wants the implant. You want to send him back? No. Let me become competent enough in doing those cases as well. As I told you, age is not a limit for knowledge. I don't mind spending some money to gain the knowledge and becoming competent enough to or do all sorts of cases and help the patient in living a very good and comfortable life. And the most important part is when they start eating the food comfortably, the expression they have when they come for the follow-up is amazing. And they pray for you. That is what we are here for. And that is what we want from the patients. And as I have to keep telling you, we are not doing this service for free. We are charging them, but give them the best. Okay? So join the programs to upgrade your skills in the field of implant dentistry with the best of the faculty in Osstem, India. So one of the best company which I have come across, and I'm there with them from past 14 years, 13 to 14 years, I'm with Osstem, and I'm happy enough with their service. Okay. So you can take a call whether you want to join a basic program so that you can start practicing implant dentistry in your clinic as well. So another case, fractured 1.5. Patient comes with a fractured 1.5. Once a fixed process is done, what should I do? So radiographs before extraction, after extraction, after placement of the implant. Then the surgical photos. Extraction with periotomes and luxators without damaging the buccal plate, which is very, very important. Then paralleling pin. We use the glass itself as a paralleling pin, and then we place the implant. There was some amount of jumping gap, but again, there are a lot of protocols to be followed. So we did some amount of grafting. We just pushed the graft bone, the Osstem graft bone again. They have AOS and QOS, a very good graft material. And I'm using them from the past 6 to 7 years. Absolutely good. Not having any problem with them. So they have all the options. So you can get all the materials which you want on your table from one single company. And then healing abutment, impression coping, close open tray impression coping done, impression taken, and then they fix the crown. Okay. So I think we are almost all done by 1 hour. I'll just show you one more case. So what are the advanced techniques in implantology? The advanced technique in implantology, as I told you, digital implantology, immediate implant techniques, advanced bone augmentation techniques like sinus graft, ridge expansion, wrist split. As I told you, start walking, start crawling, walk, and then start running. Straight away, don't start running. So take the baby steps, get yourself competent enough, invest in the armamentarium, invest in the best of the armamentarium. Don't take the armamentarium which will last just for 6 months or 7 months and keep on taking the armamentarium again and again. And then we have sinus augmentation procedures. And then we have the zygoma and pterygoid implants, short, narrow, and tilted implants, soft tissue management aesthetics, laser-assisted implantology, another big field which is coming, management of complications, robotics, and AI-assisted implants. Okay. And then, are you confused? There are so many kids in Osstem itself. But each kit has its own role to play. Placement of implant. I require a taper kit. Exit kit. I require it for ridge expansion and ridge split. Then I have the cascade for crystal approach of sinus. 5 to 6 mm of available bone is there. I can lift the sinus floor, place the implant without doing the graft. I can use the cascade. Or there is totally pneumonous sinus. I can use the last kit, lateral approach sinus lift kit, do some amount of grafting, come back. And then we have something called as one guide kit, which will help you in guided surgery. And then we have something called as titanium mesh, where you can use it for grafting procedure, for GBR, for holding the bone. They have the titanium mesh, which are very, very, very good. I've done with some of the cases with excellent results. So, and let me come to this. Let me skip this. I'll show you one more case before I close the session. These are the various systems where we have to use. Again, it will be dealt in detail in this thing, in your basic course. Okay, this is another interesting case. A very, very young boy. He was somewhere around 23 years old when I did this procedure on him. Young boy, history of accident. He has gone to another dentist. He has given a very, very bad flipper. Look at how odd that smile is. And he has come to your clinic saying that, sir, I want to improve my smile. Can you help me out? Then we started doing the procedure. See the switches, how odd it is looking. This type of patient, they hardly talk. They are ashamed about talking. They don't have a very good social life. They don't have a very good personal life. They hesitate to talk. We are here to help them out. For God's grace, God has given us the knowledge. God has made us competent enough to solve this type of problems. Okay. And then we started taking the photographs. See that situation. Because of that flipper which he had used, the adjacent state has started moving. They were almost on grade 3 mobility. Huh? The patient is not laughing, is not talking comfortably. We extracted the teeth. We prepared a surgical stent because this was done long back. So there was no digital dentistry that time. We did a surgical stent. So we opened the flap, placed the stent, we placed the implants. Some amount of grafting was done, GBR. There was a very big jumping space. So we did some amount of bone grafting as well. And then we sutured it. And then we immediately temporized it. This is how it looks. See the difference in his smile. Can you appreciate it? See how he came and how he's going out after 4 or 5 months. This is what the patient wants from you. And this is why you are here to learn. And this is what you want to learn. Don't mind spending some extra money to gain the knowledge and to become competent enough. So, this is how we finish the case. This is during the surgical phase, healing abutments. You can appreciate this soft tissue. And this is the lap work. And this is how it was finished. This is how the crown should look in the aesthetic zone. See that smile which he has now. So any questions? I was supposed to take about grievances, but the time is very short. I have a case posted at around 4:30, where I have to place 4 or 5 implants in the patient mouth, 4 implants, I think. So I have to rush back so that I can prepare to place the implants in the patient. I have a case posted at around 4:30. So any questions you have, you can post it in the YouTube channel. I am there to answer the queries. And it was very good giving a lecture to you people yesterday and today. And a special thanks and a big round of applause for the whole Osstem team, particularly Lome, Sanket and the team who have taken the trouble in making this program a successful one. And anything else you want, you can be in touch with the concerned persons in your area so that they can help you out. So any questions you had from yesterday, if you have posted, I'll get back to you with the answers. And today, if you have any queries, you can just post it in the DenAll YouTube channel so that I can help you out in answering those queries. So make sure that you become competent enough to start placing the implants on your own rather than assisting. So make sure you take up the programs which are having the best of the faculties and best of the mentors who will guide you in your journey in the field of implant dentistry. I know it is very tough in the beginning, but once you start practicing, it will be an excellent journey for you. I'm into this journey of implant dentistry from past 15 to 16 years, and I'm really enjoying it. And all the best for your future in implant dentistry. Take care. Bye. See you again if God permits. Thank you.